Welcome back to the Curbsiders. I'm Dr. Matthew Watto, here with my great friend and America's primary care physician, Dr. Paul Nelson Williams. Hey, Paul, how are things going?
I feel like you have expectations for an answer when you ask like that, but things are okay. Thanks. How are you doing?
I'm doing well. We're going to talk about a little bit about the treatment of the vasomotor symptoms of menopause. And Paul, let's start off with actually non-pharmacologic therapy, which probably maybe some people think it's boring, but I think it's important. And you're America's primary care physician, so I know this is right in your wheelhouse.
Yeah, well, I mean, I don't think people think it's boring. I think that the struggle is you worry that you don't have enough time, and sometimes it feels cliched. But it turns out that a lot of the stuff that we recommend in primary care also helps mitigate the vasomotor symptoms of menopause. So things like sufficient sleep, I know easier said than done. Getting routine exercise and weight loss, Dr. Christmas emphasized, can go a long way towards some mitigating some of those symptoms as well. So a lot of the conversations you're already having in the primary care setting, you're well suited to kind of at least reinforce those points or sort of use this as an additional carrot to kind of move the needle because it will actually help with their symptoms.
Yeah, and those are easier to access than like cognitive behavioral therapy or hypnosis,
Or
I'm sure.
hypnosis,
Which
right?
which do actually work if you can access them. They do actually work. What about medications that are not hormones, Paul?
Yeah, we covered a lot of options. For in terms of the SSRIs, paroxetine is the one that is FDA approved for the vasomotor symptoms of menopause, and we had a conversation about the potential side effects. But you use this at a lower dose than you would for, say, depression or anxiety, which is probably important to know. The SNRIs, and I think specifically venlafaxine, there's gabapentin, and then there's the new kid on the block, fezolinetant, which is a also non-hormonal stuff that is relatively new. I think we're seeing being direct to consumer advertised now, which is very exciting. Matt, remind me what am I to do with this, and how
Right.
how are we using it?
We did cover this on an episode of Hotcakes where we found out that they tested this in women who had moderate to severe hot flashes. It did work better than placebo. I think they had something like 2 less hot flashes per day. But, I think the placebo group was having 7 hot flashes at the end and the treatment group was having 5 hot flashes a day at the end. So, but it did it did work. You do have to monitor liver enzymes at 0, 3, 6, and 9 months for the first year of treatment, because in some of the other in some of the trials there was a little bit of liver enzyme elevation, but it's more other drugs in this class that have been tried in the past had more significant liver enzyme elevation, so that's why they're watching out for that. So I think this is something you can consider. Certainly it's being advertised, so patients are going to ask about it. But Paul, there is hormone therapy, and probably the pendulum has swung too far away from using that. So tell us, like, what is it used for, and where are some situations that it's approved?
Yeah, I think we've gotten very gun shy about using it. I understand the reasons, but just to review the things that it's actually approved for is, and the thing we talked most about is one, for the vasomotor symptoms of menopause, two, the genitourinary symptoms of menopause, and there are topical preparations that are also certainly options too. Osteoporosis prevention, which is one I forget about, but it does indeed exist, and then premature menopause being the other indication for hormone replacement therapy. And I should mention that for women with premature menopause, and this is due to ovarian failure before the age of 40 or surgical menopause, the idea is that you treat with hormone therapy until about age 52, which is thought to be the natural age of menopause, and then you would hopefully stop at that time, and the patients would do okay.
You would continue it at least that long. And what we talked about on the episode with her is there's no real, like, you don't have to stop at any specific point. It's you sort of use the lowest dose for the shortest amount of time, and you try to take people off. But she did mention that some people are, quote, Paul, chronic flashers and just might need to stay on therapy for a long time. And
Right,
so,
and really, and framed it as a shared decision-making conversation.
yeah,
Like there were patients who understood the risks and were still happy to continue because they felt so much better with the medication than without it. And I
yeah.
think that's a very reasonable approach as long as we're all educated and we document it well.
Yeah, and they're still being monitored, their regular breast cancer screening. If they have a
Right.
blood clot, that would probably be a reason to stop giving it to them, and that sort of thing if their cardiovascular risk changes. But for most patients, who you can, and we talk about this, or we have talked about this on the show in the past. Most patients, if they're less than 60 or less than 10 years from menopause and they're having really severe symptoms, they've tried some other things, hormone therapy may be reasonable. Dr. Christmas told us that she often will start with like a medium dose of estrogen, because in her experience, it tends to work for most people. And if you start at too low of a dose, patients might think it's not going to work and kind of give up on the therapy. We have on our website just a list of just all different types of preps and formulations. So you can click on the link down in the transcript there to get that. And you can listen to the full episode, because this was really like a masterclass with somebody who helps write the guidelines and was just knows everything, has a lot
Yeah,
of great
she's
scripts
incredible.
on how to counsel your patients. So I highly recommend that people check that out. Um, so, Paul, with all that, I guess we should wrap up and say that this has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Cuckoo, cuckoo, Watto.
I feel like this is going to be harder for you, just coming up with a different one every time. But all
Yeah,
right, until
that'll be
next
all right.
time, I've been Dr. Matthew Frank Watto.
And as always, our main Dr. Paul Nelson Williams, thank you and goodbye.